Good morning and welcome to Global Healthcast, brought to you by Global Health Press. Once a week, we bring to you news and views about vaccines, vaccination, and infectious diseases. I am Joe Schmitt, and with me, as always, is Dr. Melvin Sanicas. Good morning to Switzerland. Good morning, Melvin.
Good morning, Professor Schmidt, and good afternoon or good evening to everyone who's watching us today.
Today, I have a surprise for Melvin and also for everybody on the call. What happened is that the University of Leeds School of Medicine in 22 and 2023, they had among 14 universities, alumni from 12 different countries named national or global finalists and winners in the British Council Study UK Awards, more than from any other UK institution. And one of the nominees is a hero of the pandemic, Melvin Sanicas. Congratulations, Melvin. This is very good news. I saw it this morning. During COVID-19, this is the announcement, physician scientist Melvin Sanicas became a source of vital health information for thousands in the Philippines and around the world. Congratulations again, and I think this is a wonderful achievement.
Thank you very much, Professor. And I really thank the University of Leeds for this incredible honor. It's really humbling as well.
Wonderful, and a wonderful picture. So great start into the next year, I guess. What we will talk about today is the holiday heart syndrome, what you need to know, long flu and COVID flu we will cover. We will cover more on anthrax that we started reporting about in our last session. And I will cover prevention of long COVID, viral rebound after paxlovid, and use of Simvastatin in COVID-19. And finally, we cover criteria for addiction. I think this will be particularly important for the holidays. But again, we start with the holiday heart syndrome. Melvin, what is this?
Yes, so holiday heart syndrome is a known observed phenomenon in the medical community where the rates of heart arrhythmias tend to spike during the December holidays. So it's basically atrial fibrillation or an irregular heartbeat that's associated with binge drinking. So while this can happen any time of the year, it's most common around end of the year holidays when festivities are at an all-time high. We have all these Christmas parties and reunions with friends and family. So the risk is higher if you already have heart issues. And I think what we're just trying to say here is that it's really about keeping things in moderation, especially the alcohol consumption, right? As this is the biggest agent of heart arrhythmias. And of course, another way to combat the serious consequences of holiday heart syndrome is to understand the symptoms of an arrhythmia. So one big symptom to watch out for is the feeling of fluttering in your chest. When you feel these things, you should be very careful. And if you are high risk, the suggestion is for you to be observant. And also, if you really are not feeling well, go to see your doctor, right? I think
Yeah.
that is what we're trying to say here.
Yeah. So be aware of the symptoms and I guess avoid too much alcohol. There is
Yes.
nothing wrong with having a glass. As always in life, it is the right use. And as people said in the Roman ages, usus justus, the right use of things. So to have a glass of wine, nothing wrong with it. But having a bottle of wine is probably too much. And
Or maybe
I
two
did.
bottles of wine. Yeah.
Yeah. Yes, alone, right? That is even
Yep.
worse. Look, I thought holiday heart syndrome is something that has to do with your sweetheart. I wasn't aware that this is a term to be used with alcohol abuse and atrial fibrillation. That I didn't know. Very interesting. Yeah. Melvin, you have another story on long flu, and actually, I missed that diagnosis as a pediatrician. I was not aware of long flu, but you will tell us all about it.
Yes. So, we have been talking about long COVID for almost 2.5 years or 3 years now, right? But this study actually shows that in the 18 months after a serious COVID or seasonal influenza infection, patients are at a higher increased risk for death hospital readmission or health problems affecting a number of organs even. So this happens in patients who had flu and patients who had long COVID. But this study from the Veterans Affairs of St. Louis in the US, in the Washington University in St. Louis, the natural comparisons made between COVID and flu showed the researchers that long flu is real, it happens as well. But the ones that happened for COVID, the long COVID patients, had 50% higher risk of death. They have much more of a significant risk for mortality, and the health risks were higher after the first 30 days of infection for both flu and for COVID.
Interesting. So the lesson learned is for viral infections of the respiratory tract, likely it's more systematic. It may affect other organ systems, more so with COVID than with the flu. And you may have long-term consequences. And for flu, we didn't really appreciate them in the past. Again, as a pediatrician, I was not aware of this, but for COVID, certainly I am, right? So interesting. Yeah.
Yep.
Melvin, what happens with anthrax? You spoke about the anthrax outbreak in Africa at our last Global Health Cast. What's the follow-up?
Yes. So the last time we talked about anthrax as well, but the interesting thing is that now there are 5 African countries. So there's Kenya, Malawi, Uganda, Zambia, and Zimbabwe. They are experiencing anthrax outbreaks now. More than 1,100 suspected cases and over 20 deaths now. And Zambia is seeing the most number of cases and deaths. So scientists have really been struggling to understand the source and spread of the outbreak, as it seems to be unique, right? Because it happens sometimes in some of these countries, but it hasn't really happened like this, that everything is happening all at the same time, right? So they're trying to see what is happening, but the outbreak appears to be limited to people who ate contaminated beef. And Uganda has now banned beef sales in response to this outbreak. And so many of the affected patients have sought out traditional healers over clinics because they believe that this is caused by witchcraft or something. And so that is also maybe adding to the problem, because instead of going to the doctors, they first go to the traditional healers. It's also important to know that there is a vaccine for anthrax, but it's not available in Africa, where the threat is more prevalent.
Yeah, I guess there may be a licensed vaccine, but maybe even the vaccine is not produced and it's nowhere in a fridge, right? It may not be available even because and it may take half a year to a year before you have any doses available.
Exactly.
Yeah, that is interesting. Yeah. So do they provide a little bit more information on the clinical presentation, or is this just epidemiological study?
Well, the clinical presentation is usual, not really different from the previous cases. But I think what they're trying to do now is to understand whether these outbreaks are really related to each other, or is there some reason why this is happening now? Because we know that these outbreaks happen sporadically. There are seasonal outbreaks. And we also know that humans are exposed to bacteria most often through infected animal carcasses or contaminated animal products, especially those of cows, sheep, and goats. But they're trying to see whether there's something different, why all these outbreaks are happening now at the same time.
Yeah, interesting. Yeah, much to be learned. So let's follow up on this. This looks like an interesting story. Yeah. I have one piece of information which we covered several times in the past. It is post-COVID condition, PCC, or you can say long COVID. And what you see here is in the upper curve, in the unvaccinated, you have an incidence of post-COVID condition of roughly 2 here in this scale. And you have it for vaccinated subjects with 3 doses, it is below 1. So there's a huge difference between vaccinated and unvaccinated subjects with the risk for coming down with COVID. And this was a large study based on databases from Sweden. You see here a huge 6-digit number of subjects involved in this type of study. And the main message is COVID-19 vaccination reduces the risk for long COVID. Actually, while I'm sitting here alone in my office, I have COVID for actually since yesterday. I tested myself yesterday. I have a little bit of sore throat and a runny nose, as you may be able to hear. My wife, this is where I got it from. She is a singer in a choir, and she had it first, and now I have it. What can you do? We're both vaccinated, so I just think it is a good idea to get enough vaccine doses to make sure that post-COVID does not happen to you. Melvin, any comments on post-COVID and vaccination?
Yeah, I think, Professor, we now have enough information to tell us that really, if you want to reduce your risk of long COVID, get the vaccine, because we have all these studies now from the past 2 years, and we can convince the people who are actually receptive to information, but the others who have already convinced themselves of misinformation, we can't do anything about that.
Yeah. All right. Then let's go to viral rebound after paxlovid. There are a few viral infections we can treat today. And it is influenza, it is herpes simplex, it is pseudomegalovirus, but also we can treat the COVID virus, SARS-CoV-2. And the information that you see here is what is largely not well understood and which is debated is what is called viral rebound after paxlovid. You treat a risk subject with COVID with paxlovid, and then the cultures turn negative. And then while the cultures are negative for a couple of days, you retest again, and the person is shedding again the SARS-CoV-2 virus. And this is a study just to show, an observational study just to show that in this study, 1 out of 5 subjects came down with viral shedding after paxlovid treatment. And actually, half of patients even had symptoms after paxlovid was stopped. And this is not of clinical concern. There is no paxlovid resistance and no viral mutation involved in this phenomenon. It has an impact insofar as people who shed again the virus, they certainly may infect others. So this is a disadvantage. But still, as the I guess most colleagues would agree, a risk subject with COVID-19 should receive paxlovid, even if viral replication, viral rebound may happen. Very important. This should not be an indication to not use the drug, but it should tell you we use it, but we know about the problem. To be aware about the problem is the issue, and maybe isolate the patient from other risk subject after you stop paxlovid. But again, if you are if you have a benefit from treatment, you should use it. The question is then, why is this? Why would there be a rebound, a viral rebound? And one of the ideas here is that the duration of treatment is not long enough. Currently, the recommendation or the license for paxlovid treatment is 5 days. It may well be that the coronavirus is hiding in cells where the paxlovid doesn't reach the machinery so that the virus can continue to survive and replicate. And once you stop treatment, this is when viral replication comes again and viral shedding. But again, the main information is, yes, this may happen. 1 out of 5 subjects, this is what we see, but there is a huge benefit, and you should receive paxlovid if you are a risk subject or a high risk subject for severe disease, hospitalization, and death. Any views from Melvin? What do you think?
You know what I just think about this is I was also reading another study recently published saying that if you use paxlovid in the first 2 or 3 days after symptoms, really you are able to reduce the risk of death by half. And I think that is the main message. Whether this is happening or not, whether the viral rebound can happen with Paxlovid or not, I think what's important is that if you're high risk, take the medicine, take the drug as soon as possible, really to reduce your risk.
Yeah, we agree. And let's see what you think of the next story. Some 10, 20 years ago, there wasn't much we had in our hands for offering patients as a treatment in case an influenza pandemic would occur. And one of my friends at the time, David Fetzen, who retired a long time ago, David had the idea, if there is nothing we can offer, we can perhaps reduce inflammation. We cannot reduce the influenza virus. We cannot treat the virus specifically. That was, again, decades ago. But what we could do is reduce the inflammation and the severity of symptoms, and patients may not die from pandemic influenza. So I'm not quite sure where we are with cholesterol synthase inhibitors and influenza, but the idea was lingering around, and now somebody took up this idea for COVID. The idea is high-risk subjects with severe COVID in the hospital, people who are at risk for organ failure, heart failure, or lung failure. You give them Simvastatin, a cholesterol synthase inhibitor, but also a drug that may reduce inflammation. Now, people did this study here with an appropriate number of subjects, and you see here the cumulative proportion of organ support-free days. So people that do not need intensive care measures specifically for their survival. And what you see here, the two curves among the controls who did not receive Simvastatin and the Simvastatin recipients does not really is not very much different and overlaps in the end. So there is no benefit from this type of treatment with regard to reducing inflammation. And I guess negative results are hardly made public, but I thought this is very important to tell people that is not something you should do. And by the way, many people who are at risk for severe COVID may take cholesterol synthase inhibitors anyway because of age and high cholesterol levels. So I guess at this point, this is a negative study and something you should not do. Any comments from Melvin, from your side?
No, I think for me, Professor, it's understandable, right? When we don't have anything to offer, maybe we can use something that's already existing. But, for me, maybe the reason why it did not work is because the dose was not enough. Like, the Paxlovid issue, right? Why is it rebounding? Maybe the dose was not enough. Yeah.
Yeah. Yeah, look, at this point, I think we do have treatments for COVID, and people know what to do in intensive care. So it would only be an additional effect. And yeah, at this point, this is something people will not pursue any longer. Yeah. Now I'm closing the circle. I'm coming back to the holidays, and I'm coming back to the holiday heart syndrome. And what I want to cover a little bit is addiction. I found a nice article in the New England Journal of Medicine on cannabis addiction, but I think the criteria that you see here for cannabis addiction also apply for smartphone abuse and for alcohol abuse. You are at risk for addiction with your smartphone, with cannabis, with alcohol. If there is impaired control over the alcohol, smartphone, cannabis use. For example, if you use alcohol for longer periods of time or for higher doses than intended, if you start out saying, well, I have a glass of beer, but then you have 2, 3, 4, 5 bottles, you cannot control the use of alcohol. And the same is true for smartphones. If you use it more than 2, 3 hours as planned, you cannot control it anymore. That may result in social impairment. You cannot do your work anymore. You fail at work, you fail socially with contacts to your peers, to your friends, to your family. And then the next step would even be risky use. You drive after drinking alcohol. You drive with a smartphone in your hand, your car, and you may have a major accident. So another sign of addiction of whatever type. And finally, there may be pharmacological indicators, and that, interestingly enough, also applies for smartphone abuse. There's tolerance. If you abuse your smartphone, if you use it too much chronically, then you may become a different person and you may see physical effects of not using it anymore, of withdrawal in the end. And that is a dangerous situation. So with these 4 criteria, please watch out over the holiday, not only for cannabis addiction, but also for alcohol and for smartphones, tablets, computers. Melvin, any ideas on this one?
Yeah, it's similar to what we have discussed with holiday heart syndrome. I think it's just with drinking alcohol, with eating too much, with using cell phone, with cannabis. I think they are all somehow related. It's they have to be used moderately, I would say.
Yeah. Usus justus is the word for it, right? The right use of things. Yeah.
Yep.
All right. What we talked about is holiday heart syndrome, atrial fibrillation, what you need to know. Long flu is something that really happens at a lower rate than long COVID, but it is real. We covered the more than 1,000 cases of anthrax in Africa, more to be followed up in later global health casts. We spoke about prevention of long COVID by vaccination. Vaccines really do reduce the risk for coming down with long COVID. I spoke about viral rebound after paxlovid use in COVID-19. And again, if needed, don't say there will be viral rebound and I do not use paxlovid, but use it anyway because it may save your life. And finally, Simvastatin cholesterol synthase inhibitors have no effect in COVID-19 patients. Finally, the criteria for addiction I just mentioned before. And having said that, I think we can come to the final slide where we tell you something nice to have over Christmas. And again, it is usus justus. Don't overuse it. And what do we talk about, Melvin? What is this?
Yes, so this is a recipe for blue wine. It's hot spiced red wine made of cinnamon, orange, cloves, and basically you mix them all up, right? You bring the water, sugar, cinnamon stick to boil and reduce the heat to low. You push in the cloves into the outside of the orange peel, place it into the simmering mixture, stir the wine while the mixture is hot, and you can drink it while it's warm because it's basically wine but more flavorful, more sweet and warm. So it's good for the holidays, for the cold season.
Yeah. And one tip from a German, it is too sweet for me to begin with, right? But don't drink too much of it. Number one, because of addiction. And number two, you may get a headache. And to avoid headache, you should actually not drink too much. And number two, use a good red wine. Don't take the bad or the poor or the cheap red wine. Take a good bottle, right? It doesn't have to be $100 bottle, but maybe a $10 bottle would do it, just to make sure that you don't get a headache. That's all I want to add here. Having said this, Melvin, Merry Christmas, season greetings for whatever religion or beliefs you have over the holiday seasons. All the best. Have a good start into 2024.
Yes, thank you, Professor. Merry Christmas, everyone. Happy holidays and have a happy celebration, whatever you're celebrating this December, and have a happy start to the new year as well.